All right, so our next speaker is going to be Dr. Maria Caicedo-Martinez. She will be presenting on the experience from a hypofractionation curriculum pilot, overcoming education as a barrier to implement hypofractionation.
So good morning, everyone. My name is Maria Caicedo. I'm a radiation oncology resident at the Colombian National Cancer Institute in Bogota, Colombia. And today I will be presenting on behalf of my colleagues our experience from a hypofractionation curriculum pilot, overcoming education as a barrier to implement hypofractionation. So we now know that hypofractionation has equivalent oncologic outcomes to conventional fractionation. It is now accepted by different medical societies, and it has the advantage of shortening treatment time. This is beneficial and might be even critical for health systems in low to middle income countries, where we know there is a shortage in both radiation oncology personnel and in radiation oncology equipment. However, little is known about how to promote its adoption globally. So for background purpose, Rayos contra el Cáncer is a nonprofit whose mission is to create sustainable access to high-quality radiation treatment through education. It works with a clinic-based approach with free educational sessions for radiation oncology personnel in limited resource settings around the world. Rayos contra el Cáncer developed a hyperfractionation e-learning program to pilot in Colombia. The program was free of charge, and it was shared through the Colombian Association of Radiation Oncology. Colombia is a South American country, and we thought it was a good option to pilot the program in, since it has a bundled payment system for reimbursement in radiation oncology. The program consisted in 1 to 2 hour weekly sessions covering 13 hypofractionation topics related to the foundations of hypofractionation, let's say radiobiology, physics, but also related to topics in breast, prostate, rectal, and CNS high-grade gliomas, where we now have a good level of evidence showing that hypofractionation is both safe and feasible. 2 electronic surveys were sent to the participants, one before the course and one after the course. Physicians were specifically asked questions regarding their attitudes toward hypofractionation, and we asked them 12 clinical scenarios in breast, prostate, rectal, and CNS high-grade gliomas in order to see how was their use of hypofractionation or ultra-hypofractionation schedules, and to evaluate if after the course there was an increase in the use of these hypofractionation schedules. We did afterwards a comparative analysis using a McNemar test. Overall, we had 149 participants across 19 cities and 46 centers in the country. For your knowledge, Colombia only has 49 centers of radiation oncology in the country. So this meant we had more than 90% of the radiation oncology centers in the country participating in the curriculum. Radiation oncology professionals that we had enrolled in the course were mostly radiation oncologists, followed by medical physicists and radiation oncology residents and medical physics residents. Colombia only has 1 residency program for radiation oncology at the moment. Most of our participants had only been in practice for less than 10 years. So at a baseline, we aim to evaluate if education was a perceived barrier for the use of hypofractionation. The cases where education were the highest perceived as a barrier was for prostate cancer, ultra-hypofractionation, followed by breast cancer, ultra-hypofractionation, and in the use of the short course in rectal cancer. So this is interesting because the highest the fraction or the dose per fraction, the highest the education was a perceived barrier. So after the course, what we saw, and overall, we had a decrease in the perception of education as a barrier amongst all clinical scenarios, although we only achieved statistical significance for breast cancer, ultra-hypofractionation, and for prostate cancer, hypofractionation. When we aim to evaluate As for the specifics in the clinical scenarios, we presented to the physicians if there was a difference or an increase in the use of hypofractionation. What we saw is that there was a statistical significant increase for early stage breast cancer in a not negative patient, in a young patient, and in an older patient, as for the use of ultra hypofractionation. In the prostate cancer setting, the highest increase was seen for the unfavorable intermediate risk. For rectal cancer, we saw an increase in the use of the short course for a T3 and a T4 not positive patient with rectal cancer. For CNS hyperglioma, the highest increase was seen in an old patient with an ECOG of 2. So overall, what we saw with our results is that education is a perceived barrier for the use of hypofractionation schedules in a low middle income country, even within a bundled payment system where we thought there was not going to be a bias, maybe by reimbursement incentives. An e-learning approach, such as what we did with this curriculum, appears to be feasible and effective at reducing the educational barrier and increasing the use of hypofractionation. What we need to do is identify those centers that are still perceiving education as a barrier and plan a follow-up with them, maybe with an enhanced training or with personal sessions. And I believe that afterwards, what we need to ask if this is that with the widespread of use of e-learning tools, if this curriculum might be beneficial in other countries different from the Colombian context. So I would like to thank the Colombian Association of Radiation Oncology for all their support, to all our educators who voluntarily share their knowledge with us, and to the curriculum participants for their high engagement throughout the course. Thank you.